Welcome to Pediatric Case Review. I'm Dr. Abdelaziz Yusuf Sabah. Today, we are diving into a very common yet sometimes tricky topic in general pediatrics, recurrent tonsillitis and the indications for tonsillectomy. We'll use a case-based approach to review the presentation, workup, and current guidelines. We'll specifically focus on the Paradise criteria and the American Academy of Otolaryngology head and neck surgery recommendations. Let's get started with our first case. Let's start with a classic presentation. A 6-year-old boy presents with a 2-day history of severe sore throat, fever of 39.2 degrees Celsius, and difficulty swallowing. On exam, he has tender anterior cervical lymphadenopathy and enlarged erythematous tonsils with patchy white exudate. What is the most likely diagnosis? Is it A, viral pharyngitis, B, group A streptococcal pharyngitis, C, infectious mononucleosis, or D, peritonsillar abscess? Take a moment to think about the key features here. The correct answer is B, group A streptococcal pharyngitis. This patient presents with the classic tetrad of group A strep pharyngitis: fever, tonsillar exudate, tender anterior cervical adenopathy, and the absence of viral symptoms like cough or rhinorrhea. This presentation in a 6-year-old is highly suspicious for group A strep. While viral pharyngitis is common, it typically presents with other viral symptoms. Infectious mononucleosis often has more generalized adenopathy and fatigue, and a peritonsillar abscess would typically present with a muffled voice and asymmetric tonsillar swelling. Now, let's consider the next step in managing this patient. Now that we suspect group A strep, what is the most appropriate next step in management to confirm the diagnosis before initiating antibiotics? A, empiric antibiotic therapy, B, rapid antigen detection test, C, throat culture only, or D, complete blood count. Consider the standard of care for diagnosing group A strep in the pediatric office setting. The correct answer is B, rapid antigen detection test, or RADT. In the pediatric setting, an RADT is the preferred initial test because it provides immediate results, allowing for prompt treatment if positive. It's important to remember that if the RADT is negative in a child, a backup throat culture is recommended because RADTs can have lower sensitivity. Empiric treatment without testing is generally discouraged to promote antibiotic stewardship. Next, we'll look at how we assess tonsil size. Let's move to physical examination. During a well-child check for a 4-year-old girl, you note that her tonsils are enlarged and occupy approximately 60% of the space between the anterior fascial pillars. How would you grade her tonsillar hypertrophy? A, grade 1+, B, grade 2+, C, grade 3+, or D, grade 4+. Recall the standard grading scale used in clinical practice. The correct answer is C, grade 3+. The Brodsky grading scale is the standard tool here. Grade 1 is less than 25% obstruction. Grade 2 is 25 to 50%. Grade 3 is 50 to 75%. Grade 4 is greater than 75%, often referred to as kissing tonsils. Since this patient's tonsils occupy 60% of the space, they fall squarely into the grade 3 category. Accurate grading is crucial for monitoring and communicating findings, particularly when considering referrals for sleep-disordered breathing. Now let's discuss surgical indications. A 7-year-old girl is brought in by her parents who are frustrated by her frequent sore throats. According to the Paradise criteria, what is the minimum number of well-documented episodes of throat infection in the past year that would qualify her for a tonsillectomy? A, 3 episodes, B, 5 episodes, C, 7 episodes, or D, 9 episodes. This is a core piece of knowledge for any general pediatrician. The correct answer is C, 7 episodes. The Paradise criteria are the gold standard for determining when recurrent throat infections warrant a tonsillectomy. The easiest way to remember this is the 7-5-3 rule: at least 7 episodes in the past year, or at least 5 episodes per year for the past 2 years, or at least 3 episodes per year for the past 3 years. These episodes must be well documented and meet specific clinical features. Building on the Paradise criteria, let's look at the specific features of an episode. To meet the criteria for a qualifying episode of throat infection, the episode must be characterized by a sore throat plus at least one specific clinical feature. Which of the following is one of those required features? A. Cough. B. Temperature greater than 38.3 degrees Celsius. C. Rhinorrhea. Or D. Conjunctivitis. What makes an episode count? The correct answer is B. Temperature greater than 38.3 degrees Celsius. For an episode to count towards the Paradise criteria, it can't just be a mild sore throat. It must be accompanied by at least one of the following: a fever greater than 38.3 degrees Celsius, cervical adenopathy, either tender or greater than 2 centimeters, tonsillar exudate, or a positive test for group A strep. Cough, rhinorrhea, and conjunctivitis are typical viral symptoms and do not qualify an episode under these criteria. Now, let's consider situations where these strict criteria might be modified. Let's consider a slightly different scenario. An 8-year-old boy has had 4 episodes of documented group A streptococcal pharyngitis in the past year. While he does not meet the strict Paradise criteria for frequency, he has a history of a severe allergy to multiple antibiotics. According to American Academy of Otolaryngology head and neck surgery guidelines, what is the most appropriate recommendation? A. Watchful waiting. B. Tonsillectomy may be considered. C. Long-term prophylactic antibiotics. Or D. Adenoidectomy only. How do guidelines handle exceptions to the standard criteria? The correct answer is B. Tonsillectomy may be considered due to modifying factors. The American Academy of Otolaryngology head and neck surgery guidelines recognize that strict criteria don't fit every patient. If a child has modifying factors, such as multiple antibiotic allergies, periodic fever, aphthous stomatitis, pharyngitis, and adenitis syndrome, a history of peritonsillar abscess, or a family history of rheumatic heart disease, tonsillectomy can be considered even if they haven't reached the 753 threshold. In this case, the severe antibiotic allergy makes managing even infrequent infections challenging and potentially dangerous. This brings us to a common differential diagnosis. Here is a classic differential diagnosis question. A 4-year-old girl presents with recurrent episodes of high fever, aphthous stomatitis, pharyngitis, and cervical adenitis, occurring predictably every 3 to 4 weeks. Throat cultures are consistently negative, and she is completely asymptomatic between episodes. What is the most likely diagnosis? A. Recurrent group A streptococcal pharyngitis. B. Cyclic neutropenia. C. Periodic fever, aphthous stomatitis, pharyngitis, and adenitis syndrome. Or D. Kawasaki disease. Pay attention to the periodicity and the specific constellation of symptoms. The correct answer is C. Periodic fever, aphthous stomatitis, pharyngitis, and adenitis syndrome. This stands for PFAPA syndrome. The hallmark of PFAPA is its striking periodicity. Parents can often predict the exact day the next fever will start. The negative throat cultures rule out recurrent group A strep. While cyclic neutropenia can present similarly, PFAPA is more common and features this specific constellation of symptoms. Tonsillectomy is actually a very effective treatment for PFAPA and is considered a modifying factor in the guidelines. Now, let's consider a serious complication of recurrent tonsillitis. Let's look at a serious complication. A 10-year-old boy with a history of recurrent tonsillitis presents with a 4-day history of worsening severe sore throat, trismus, and a hot potato voice. On exam, you note a bulging of the left soft palate with deviation of the uvula to the right. What is the most appropriate immediate management? A. Oral amoxicillin and discharge. B. Immediate tonsillectomy. C. Needle aspiration or incision and drainage. Or D. Intravenous corticosteroids only. Recognize the classic signs of this condition. The correct answer is C. Needle aspiration or incision and drainage. This patient has a classic peritonsillar abscess, indicated by the trismus, hot potato voice, and uvular deviation. The immediate treatment is drainage of the abscess, usually performed by an ENT specialist or in the ED, followed by antibiotics. While a history of PTA is a modifying factor that might lead to an interval tonsillectomy later, an immediate quinsy tonsillectomy is rarely performed due to increased bleeding risk and difficulty. Now, let's consider complications that can arise after surgery. Finally, let's discuss postoperative care. A 6-year-old boy underwent a tonsillectomy 7 days ago. His mother calls the clinic frantically, reporting that he just coughed up a tablespoon of bright red blood. He is currently alert and breathing comfortably. What is the most appropriate advice? A. Reassure the mother. B. Advise ice water and observation. C. Instruct her to bring him to the emergency department immediately. Or D. Prescribe an oral antibiotic. How do we handle post-tonsillectomy bleeding? The correct answer is C. Instruct her to bring him to the emergency department immediately. Post-tonsillectomy hemorrhage is a true medical emergency. Secondary hemorrhage typically occurs between days 5 and 10 when the eschar sloughs off. Even a small amount of bright red blood, a herald bleed, can be a warning sign of a much larger, potentially life-threatening bleed to follow. Never reassure or observe bright red bleeding at home. These patients require immediate evaluation by an ENT or in the ED. Next, we'll review a common scenario regarding management strategy. Let's review a common scenario. A 5-year-old girl has had 4 episodes of mild sore throat in the past year. 2 episodes were associated with a low-grade fever, and RADTs were